Start, please, Ram.
Okay. It's our pleasure today to have Dr. Hasan. He will speak with us a very important topic about hemodialysis, central line venous catheter access. And we have Dr. Mu'taz Fathi. He will be the moderator of the session. So the floor is yours, Dr. Mu'taz.
Bismillah ar-Rahman ar-Rahim. Thank you, Rami. Welcome in this new meeting of Egyptian Society of Nephrology and Transplantation. And I thank Rami Abu Bakr for his effort as he is our coordinator today. And we are today in the meeting of interventional nephrology meeting that will be by Dr. Hasan Foula. He is consultant nephrologist and head of interventional nephrology department at Kabari Hospital in Alexandria and in ISN Interventional Nephrology Fellowship. Our moderator today is Professor Mu'taz Fathi, Professor of Nephrology and Medicine in Cairo University, and the head of Interventional Nephrology Unit in Cairo University, or what is known as Asr Al-Aini Interventional Diagnostic Nephrology Unit. And he is the moderator today, so please, Mu'taz, start.
Thank you, Dr. Yasser. Thanks for all our attendees and this fruitful meeting. It's my pleasure to be the moderator of this session about interventional nephrology and to present our dear colleague and our
مش واضح خالص.
حسن فولة nephrology consultant and head of nephrology department Japan. He is a lot of difficult accesses about
كده
كده واضح؟
كتير.
طيب اوكي. Sorry for this interruption. It's my pleasure today to be one of this activity, to share in this activity, and I'm saying hi to all attendees. And it's my pleasure to present Dr. Hasan Foula. He is a nephrology consultant, head of nephrology department at Bari Hospital, and he has a scholarship before in Japan with the vascular access activities regarding thrombectomies and management of fluid air fistulas, and he has another activities in our society, Egyptian Society of Nephrology and Transplantation, regarding workshops, lecture in the workshops, and he is now gonna have this presentation about basics of hemodialysis central venous catheter insertion, and we are welcome, Dr. Hasan. Thank you.
Okay, thank you, Dr. Mu'taz, for your kind presentation, and thank you, Professor Yasser, for the kind invitation for this meeting. And it's my pleasure, of course, to be one of the CME activities of the ESNT. So, as regarding the topic that I had requested to prepare, it is the basics of hemodialysis central venous catheters. So we will talk briefly about this agenda. the basics of the planning for hemodialysis catheter, basics of catheter insertion, and basics of early catheter care, and basics for routine catheter care. And I think the time will not include the catheter malfunction and catheter-related infections, and we can prepare another meeting for these topics, of course. So to start without delay, let's start with Mr. Ziad. He is a 45 years old man who presented to the ER with accidentally discovered renal impairment. His creatinine is 10.6 and the urea is 335 and severe hyperkalemia of 7.5. So his physician, which is us as a nephrologist, ordered an emergency hemodialysis session. So when we order an emergency hemodialysis without an access, so we ask ourselves about what is the best vascular access now for Mr. Ziad. So as you all know, we have three main types of vascular accesses, the hemodialysis catheters, the fistula, and the grafts. So the ideal access should be not synthetic, should be easy to construct, easy to use and readily used with adequate blood flow. It should be long lasting with no infections and no thrombosis. And if we imagine the three types of vascular access that we mentioned, we will find that we have no ideal vascular access in nephrology. And it is one of the most problematic things we have in hemodialysis, that no ideal vascular access at all in the hemodialysis. So the physician ordered to choose, of course, a hemodialysis catheter because it is an emergency situation with severe hyperkalemia. So the second question we should ask, what is the best type of catheter to be inserted to help Mr. Ziad at this situation? We have, of course, three types of hemodialysis catheter. The first one is a short-term catheter. As you all know, it is very easy to insert with less complication, less time consuming to insert, but it have a poorer quality of material, which is rigid material, more prone for vein thrombosis. And the other type is a long-term catheter, which we call always a long-term or permicath or tunneled catheter. So the tunnel catheter is not easy to construct. It usually need more training than the short-term catheter. It is tunneled under the skin with the Dacron cuff, so it is less in infection rate compared to the short-term catheter. The third type, which is in Egypt, the soft short-term catheter, and we call usually in Egypt the midterm catheter. The midterm catheter usually combine both the short-term features and the long-term features in one catheter. And we have published the innovative method of insertion of the tunneled short-term catheter as an emergency situation in the era edita previously in 2019. So I think the preferred catheter type now for this emergency situation with severe hyperkalemia and uremia is the short-term catheter, of course. So the third question we should ask ourselves before inserting the catheter is, what is the approach for inserting the catheter? So usually we insert the catheter in three main veins as an emergency situation. The jugular veins, they are safe veins because they are very easy to recognize if the bleeding occurs, with a low risk of pneumothorax or hemothorax. But they still have the risk for carotid puncture, and of course it is not usually comfortable for our patients as a line. The second approach is the femoral veins. It is very easy to find. It's suitable for emergencies, but it carries the risk for DVT and infections. And of course, it's not suitable for ambulatory patients, as you all know. The third vein is the subclavian vein. It is the most comfortable to contrast patients because the catheter will be in the shoulder, but of course it is deep, non-compressible vein. So if you have by mistake an arterial puncture, it will be a disaster. A very high risk for pneumothorax and hemothorax because the subclavian vein lies over the pleura. And of course, it is very obsolete because the subclavian vein is the main drainage for the upper arm veins. And as you all know, that we should preserve our upper limb veins for further fistulas or grafts. So the subclavian vein is now an obsolete. And as I remember in Damanhur, where I have learned for the interventional nephrology, to insert a subclavian catheter, we should consult the most senior consultant in the unit before inserting any subclavian vein. So please don't insert subclavian catheters as much as you can. When we choose the right axis, we usually consider also the contraindications, which is usually infection, distorted anatomy like burns or trauma. We have sometimes patients with car accidents or severe burn. So we sometimes prefer some sites over the sites according to this anatomy. Of course, if there is a vascular injury or patients who are uncooperative or acidated patients, patients with bleeding disorders or receiving certain drugs like anticoagulation or patients with severe hypertension. So we usually consider these items before inserting the catheter or choosing the preferred site for insertion. The third question is what is the best catheter design for Mr. Ziad? We know that we have the straight catheter type, the curved catheter type, and the pre-curved catheter type. According to the site, you will insert the catheter. It is preferred which type of these designs. So we don't usually like this photo on the left of the screen with this catheter, straight type catheter in the neck, and these sutures, which is, as you see, macerated or shaddal skin. The second type, which is the curved extension line, is preferred in the neck approach or the jugular approach. And usually we don't like at all this curved type in the femoral approach because it is nearly in the groin with very high risk for contamination and infection. So according to the site of insertion, we usually choose the right catheter design. So please make all catheter designs at your hospital because we don't know when the patients come what is the type of catheter which is better for him. So all designs are available, and as we mentioned, each type or each design is more preferable than the other in certain sites. And be aware that in some situation, in patients who are admitted in the ICU, we have the triple lumen catheter, which is more useful for ICU patients as we have only a single central venous catheter with single venous puncture for those patients, with 2 lines for hemodialysis and a single line used for drug administration. The fourth question we ask for ourselves before inserting the catheter: what is the preferred catheter length? We all know that short-term catheters have 2 main length type, the 15 centimeter and the 20 centimeter. And we usually insert the 15 centimeter for the right internal jugular and the 20 centimeter for all other sites for insertion. So please provide yourself in your hospital with all catheter lengths, because inappropriate catheter length will result of course for catheter malfunction after that. So now we have chosen the catheter type. We prepared our minds for the site for insertion. We prepared the catheter design and the catheter length. So before inserting the catheter, please note that we have a certain pre-insertion prerequisites that should done before each catheter insertion. We should take a detailed history about the vascular access. If the patient has previous vascular access, and when he inserted these access, and where, and who tried. When we are told that the junior doctor have inserted or have tried to insert the catheter and he is failed, we should be cautious as much as we can. If there is any complication previously, any doctor, he told him that it is a problem in his insertion or not. He has any comorbidities, recent DVT, he has hypertension or not, he is receiving any drugs or not. So we should take a detailed history before inserting the catheter. Not only the vein and the catheter and to insert, we should have a detailed history. We have also to request some lab investigations like CBC and CRP and coagulation profile before inserting hemodialysis catheters. And please note that there are now some drugs that can cause bleeding without affecting the coagulation profile, which are the new oral anticoagulant. So even if the INR or the coagulation profile is normal, you should take the history from your patient that he is not receiving any anticoagulation. And the third prerequisite is that the ultrasound mapping. Ultrasound mapping is mandatory before inserting the catheter. We are what we see this vein, the internal jugular vein, and this is the common carotid vein. And we in each segment of the vein we do compress with the ultrasound probe. While compressing, if the vein is completely collapsed like this, so it is usually free and with low venous pressure. So we are comfortable to insert a catheter in such a vein. But if the vein is not compressible or it has some collaterals, we usually should be afraid before inserting the catheter. So we see the vein along its course from the beginning and then down until its drainage. We should do this mapping for all veins that we insert before attempting to insert, because we should have a plan A and plan B and plan C before insertion. So I should prepare my mind before getting for the patient what is the preferred access now. If I failed, what should be the next access for these patients? And if I failed, what is the third access? So we scan usually the common veins for insertion, like the internal jugular veins, external jugular veins, subclavian veins, and femoral veins and external iliac veins, before each time we insert the catheter. Even if the patient have the first time to insert the catheter in his life, we should usually insert. We should usually map his veins before insertion to prepare ourselves. So again, before inserting the catheter, we should do the informed consent. The informed consent should be including the indication for catheter insertion, the complication that may occur while insertion or after insertion, and should be signed by the patient and his witness or his relatives. So before inserting the catheter, we should have the informed consent. It is more safe for us as doctors. It will provide more information for the patients, so the patients can accept or refuse your treatment plan. So please make sure that you have an informed consent before each catheter insertion for each patient, as we mentioned before. And we should prepare our intervention unit. So it is our intervention unit in our hospital. It should contain the bed and the ultrasound machine, and of course the crash car for any emergency situation. So after we inserted for Mr. Ziad a catheter, he was admitted, and we showed the femoral catheter, which was 20 centimeter straight type, to receive 2 sessions of hemodialysis. Ultrasound abdomen for him showed bilateral small kidneys, and he was diagnosed as end-stage renal disease patients. And he was discharged after these 3 days with close follow-up after we have removed the femoral catheter. So after 1 week, he become better, and he have come for follow-up in the clinic with creatinine 6. His vascular surgeon created an AVF for him, but of course it is not mature till now, and he needs again a hemodialysis. So we will ask again about the best catheter for him. Is it the short-term catheter, the long-term catheter, or the soft short-term catheter? In my mind, or in my opinion, or in the literature, you should know that the short-term catheter should not be inserted for more than 2 weeks at all. And the long-term catheter should be inserted if the patient has to insert the catheter for more than 2 weeks or up to 12 weeks or more long. So in this situation, we have the patient who is end-stage renal disease. He has a fistula with 1 week age. It is created 1 week ago. It is not mature at all. So it will function at least after 5 weeks from now. So the short-term catheter, of course, will not be appropriate for him. So the long-term catheter is now the appropriate choice. Please note that any patient with a immature fistula is valid for long-term catheter insertion. It is not valid at all to insert a short-term catheter for patient who is not in an emergency situation. The short-term catheters is only for the emergency situations, as we agree. So the best catheter now is the long-term catheters. And you should know also that the permicath is not a permanent access. We usually see some patients who insert the permanent catheter or the permicath or the long-term catheter as a bridge till he will get his transplanted kidney without any further plan for transplantation. He don't have any donor or potential donor. He didn't prepare anything for the transplantation till now. So in these patients, the permanent catheter or the long-term catheter is not the appropriate choice. This patient should have a permanent access, which is usually the AVF or the AVG. So please change our mind. The permicath is not a permanent access. We should inform ourselves and our patients that permicath is not a permanent access at all. So I think with Mr. Ziad, we have the basics of planning. Then we have the basis of catheter insertion. So for safety of ourselves and our patients, we should have these 3 precautions. Please properly hand wash your hands. Surgical hand wash is mandatory before insertion for your patient safety. We should wear the full PPE or personal protective equipment, including the mask, the overhead, the eye goggles or the face shield, the sterile gown, and the sterile gloves. So the safety of you as a physician and the patient as a patient should be first. And we should also insert the catheter with complete aseptic technique. Sometimes we have some junior doctors who are not aware about the aseptic technique. So they open the catheter in complete aseptic technique. Then while insertion, the guide wire goes for to touch anything or any surrounding, and he continue to insert the catheter. It is a crime to insert the catheter without complete aseptic technique. And without complete hand washing, and without complete full personal protective equipment before insertion. We usually have the patient position to congest the vein. If we will insert the catheter in the upper body, in the jugular veins or the subclavian vein, we usually have the patient with the trembling position and with extended neck. And if we insert in the femoral vein, we usually position our patient in the reverse triangular position to congest the femoral veins. And usually we also open the angle for cannulation. The internal jugular angle is very narrow angle, so we should put our patients for the lateral position and the extended position. And we usually overextend the neck with a pillow under the shoulder. And in the femoral catheter, we also open the angle with the frog leg position, which is the external rotation and abduction of the thigh. So the patient position is important to insert the catheter safely and easily. We should congest the vein and open the angles for the catheter insertion. The operator position also is important, because as you see, this operator will end up by back pain and neck pain after a list of 3 to 4 catheters per day. In my hospital, we may insert more than 5 to 6 or more catheters per day. In the Manhur hospital, we were inserting more than 20 to 30 catheters per day. So if you don't have the proper position, it will end up by your neck pain and back pain. So what is the proper position for you? The table and the assistant should be towards the dominant hand. If you are right-handed, so your assistant and your table should be on your right side to be easily applicable for you. And if you are left-handed, the table and the assistant should lie on the left hand. In the femoral catheter approach, we usually stand on the our position, and the assistant and the table will be opposite of you. So it will be accessible over the table or the operating table to insert the catheter. And we should have the ultrasound in front of you. In some situations, in narrow rooms, we usually see our doctors inserting the catheter with like this doctor who is viewing the ultrasound in his back. So it will end up by a disaster for the operator, not for the patient. So your safety is also important. Should we use an imaging while insertion? Yes. We should use at least the ultrasound machine. The ultrasound machine is mandatory to cannulate the vein, especially if it is available in your hospital. I know that some of our hospitals does not have ultrasound machines in the interventional nephrology units, but if you have the ultrasound machine, please insert the catheter with the assistance or the guidance of the ultrasound machine in the real-time position. Why? To avoid this bleeding, like this hematoma or this patient with this pseudoaneurysm. As you see, the vein is have some pseudoaneurysm because of inappropriate cannulation, or this patient with this arterial pseudoaneurysm because an arterial puncture. So the use of ultrasound machine will, of course, help me to get rid of these all complications for the safety of our patients. So is it alone the ultrasound? We usually use the C-arm imaging also, but it's not mandatory. Our guidelines is not mandating the C-arm for insertion of catheters, even the long-term catheters. But if we insert the catheter without the C-arm imaging, we should have a post-insertion X-ray to confirm the tip location and the curve of the catheter. So the CR machine is important to locate the tip of the catheter in the mid of the right atrium and to confirm the curve is not kinked before insertion. The C-arm is not mandatory, but it is important if available. If it's not available, please do X-ray after catheter insertion. Please be delicate with the patient. Talk to him while inserting the catheter. It will make him more quiet and more informed with you. So before giving him the anesthesia, tell him that we will have a needle break with the anesthesia. Inform him that the anesthesia may be slightly painful. Inform him that we should not move our hands. Inform him before any procedure or any step of the procedure. Tell him we have the cannulated the vein. We have inserted the guide wire. We are now dilating the vein. These conversation will make the patient more quiet and more ready for the catheter with less pain. Give the proper anesthesia, and we know the proper anesthesia is what we call the xylocaine wheel, like our Professor Zarlul said to us. We should give the anesthesia in the dermis and the epidermis layers to make the full anesthesia for our patients. Move any instrument with rotatory movement without pushing. The pushing movement is very aggressive, is very traumatic, is very painful to the patients, while the rotatory movement is more safe for the patient, less traumatic, and less painful for the patient. So for any instrument you will insert while inserting the catheter, like the guide wire, the dilators, the catheter itself, we should insert while we are moving in a rotatory movement to be more safe, to be inserted over the guide wire. Please make the sutures loose, not very tight sutures for the patients, because the very tight sutures will be painful for the patients. So the loose suture is better for the catheter itself. And before dressing, please clean the betadine or the chlorhexidine before having the final dressing over the catheter. Sometimes we have patients who have inserted the catheters with betadine or chlorhexidine. Then the doctor informed the patients don't have any water over the catheter to keep it in a proper hygiene. But he usually forget to clean up his own antiseptic method, because betadine will cause a sticky environment and inviting more microbes over the skin. So please clean before the dressing. After the catheter, we usually have the early X-ray. It is usually mandatory to have the early X-ray, not only to confirm the tip position and the kink for the patient, for the catheter, but also for confirming the patient safety again. So to exclude a pneumothorax or a hemothorax, we should have a post-insertion X-ray. It will be more safe for the patient and more medical legal for you as a doctor to have a post-insertion X-ray without complication. So please request a chest X-ray after each hemodialysis catheter insertion. The acute complications include, of course, hematoma, arrhythmias, pneumothorax, and hemothorax. And as we mentioned before, the use of imaging of ultrasound will minimize the post-insertion complication, the acute complication, but of course, it will not make a 100% reduction. So please use the ultrasound to minimize these post-insertion complications. We usually tell our juniors that the good doctor is not who inserts the catheter safely, but who know when to stop while inserting the catheter. So if you inserting the catheter during the procedure, you have any problem like chest pain for the patient, the guide wire is not inserted easily or smoothly, or you have any complication for the patients, please stop and don't make further complications, because the good doctor, he is who is inserting the catheter safely without complications. The routine catheter care includes the catheter lock solutions. We all know that we have three main types of catheter lock solution: the anticoagulations, the antimicrobial, and the combination. The anticoagulant, as we know, are heparin and citrate. Heparin is more cheap. They both prevent thrombosis. They are used with different concentrations. Citrate have some antimicrobial effect, especially with the higher concentrations, but citrate has more systemic toxicity. I think both are valid solutions for our patients, but please know the difference between both solutions. The antibiotic lock is effective against the biofilm forming organism, but it carries the problem of antibiotic resistance. So it is only used in the case of biofilm. It should not be used as a prophylaxis for catheter infection. We only do the antibiotic lock when we are informed with a biofilm in the catheter to prevent this biofilm, or to treat this biofilm for a short course and then stop the antibiotic lock. Antimicrobials also include ethanol and ELITA, but I think they are not available now, and they are obsolete now to insert as a catheter lock solution. We have also the combination heparin antibiotic lock. It carries the benefit of both heparin and antibiotic lock, anticoagulation, and antibiofilm. The risk of resistance is also found in these combinations, and also it carries the risk of precipitations of either the antibiotic or the heparin if not prepared in the proper concentrations for both. And we have the toluidine-based combination. The toluidine is antimicrobial, is not antibiotic, so it has the lower risk for resistance, and it can be used for prophylactic use. And I think most of our units now have the toluidine-based catheter locks. I think we should use these lock solutions for the long-term catheters at least. Some centers have the betadine cream over the exit site to minimize the risk of contamination, but I think it is not evidence-based practice. Mupirax or mupirocin is a good practice for catheters as a prophylaxis for MRSA infection, but again, I think it should be done for a short duration. What about the antibiotic spray? I think it should be abandoned from our units. It should be forbidden in our units, especially except in certain situations when we have a catheter with some exit site infection, and we have a culture from this exit site, and we have a sensitivity for this antibiotic. So these antibiotics cause this very bad appearance. it has a powerful or a pressured powder, so it make erosions of the skin, which make it more vulnerable to infections, and it usually carries the risk of resistance at long-term use. So please use these antibiotics only for shorter duration and when indicated, not for prophylactic use. We have now the basics for the planning catheter insertion, the basics of early catheter care and the routine catheter care. To conclude my session, catheters are like these two sisters. We usually like each other, but we usually have fighting with each other. So our relations with catheters is usually like those sisters. And please remember always that catheters are not ideal solution for every patient. And thank you.
Thank you, Dr. Hasan, for this very interesting and comprehensive lecture. Really, I enjoyed it. Professor Mu'taz,
Thank
please.
you.
Mu'taz, unmute yourself, please. Dr. Mu'taz. Dr. Mu'taz, unmute yourself. Okay, اتفضل يا معتز.
Thank you, Dr. Hasan, for this elegant and informative lecture. مش عارف صوتي واضح ولا لا؟
Thank you.
واضح؟
صوتك واضح.
شكرا جدا يا حسن. كنت like to ask you about your experience about the occlusion of the catheters, especially the permanent catheters after insertion by a few weeks. What you're going to do in this situation if you have a blocked catheter, especially the permanent catheter?
Thank you for your question, Dr. Mu'taz. The catheter malfunction is not included in this lecture, but as we all know that catheter malfunction has many causes. So before attempting any procedure for catheter malfunction, especially if it is a long-term catheter, we should exclude some causes which can be done easily. So we should make IVC assessment or volume assessment for the patient to be sure that he is not volume depleted, especially if the patient has this catheter malfunction over the second half of the session. So we should exclude the volume depletion first. Then we should exclude the tip malposition or migration and the kink. Sometimes we have these problems. So we should request a chest X-ray to confirm that the tip in its right place and there is no kink in the catheter. Then we should examine the catheter itself. If the catheter is not aspirating blood and not injecting blood, so it is of course thrombosed catheter. So it should be replaced by another one, especially if it is with high pressure with no inlet or outlet of the catheter, no inflow or outflow. But if the catheter is aspirating blood, so there is a blood outflow from the catheter, but no blood inflow, sorry for the reverse, it is receiving blood well, but not aspirating blood very well. So we are usually suspecting a fibrin sheath. The fibrin sheath is the sheath that is formed around the catheter, like this. So when the catheter is aspirating blood, the pressure will be negative and the fibrin sheath will occlude the openings of the catheter. And when the catheter is receiving blood, the pressure will be high and open the fibrin sheath. So it is usually suspected by this simple test. Of course, there are other tests or other methods to confirm, like the CT angiography or injecting contrast under the fluoroscope to confirm the presence of these fibrin sheaths. Fibrin sheath disruption has many treatment modalities. The least invasive of them is fibrin disruption, or we can change the catheter over the wire with a longer catheter, so freeing up the openings of the catheter.
Thanks, Dr. Hasan. Do you use the guide wire to recanalize or restoration of the pathway of the catheter? Do you use the guide wire? Do you have a catheter block? Do you have used before the guide wire?
I know some doctors who doing that, but I think I don't do this because I am usually be afraid from pushing the thrombus inward. But in some situations we have a technique which is off-label, but I sometimes use it when I think that the catheter is partially thrombosed, not totally thrombosed. I have which I call the spiral wire technique. So I insert the wire in. I kink the wire and insert both wires in the lumen and make the rotatory movement over the for the wire, and then push it back. It is like what we call the catheter brushing. But of course, you know that we don't have the catheter brush in Egypt. So I usually, when suspecting a minor thrombosis in the catheter, I sometimes do that.
Thanks, Dr. Hasan. Let's move to the question on the chat. What's your opinion about cardiac arrhythmias and citrate lock?
Of course, citrate lock causes hypocalcemia, which sometimes may be fatal in some situations, but with higher concentrations. I think the citrate lock solutions, which is available now in Egypt, don't have this aggressive complication, because I think it is less than 40% concentration. Of course, any catheter lock have at least 20% of systemic absorption in the dialysis 3 days. So if we use a high concentration citrate, it may occur. But I think in the available solutions now, I think it is not a problem.
I think it occurs more with citrate anticoagulation during session. You know, the citrate PRRT maybe linked to
or plasma exchange.
Yes. Another question from Hazim. You mentioned that you do not recommend to use antibiotic lock. What about using this? This is the last access patients you have. We have so many patients with the last access chance.
It is a little tricky question. I think I don't like also using an antibiotic catheter lock for those patients. I think toluidine-based combinations is available in our units. So I prefer the combination with toluidine because it carries the least resistance. So I will prefer the toluidine-based, I think.
Okay, moving to another question. What about
معتز
ايوه
دكتور معتز بليز لو سمحت، انا عندي بس عايز ستريس على النقطه دي. صوتي
اوكي
واضح؟
اتفضل.
يعني do you mean Hasan that no need for antibiotic prophylaxis after catheter insertion anymore?
Of course, we don't need any systemic or local antibiotic lock after catheter insertion if we appropriately have aseptic technique.
Okay. It is antibiotic only in cases of complications or
catheter infections.
Okay, this is an important point to stress upon.
Neither local or systemic.
Yes. What about permacath in patient no symptoms, only CRP high 24? you prefer to do something to these patients with the high only CRP without symptoms, without fever, without rigors, and so on?
Thank you for the question. I think it's also tricky, but the short answer is that we are usually treating the patients, not the lab. Absence of any symptoms of catheter infection with a higher CRP is not mandating the antibiotics or any maneuver. We all know that hemodialysis itself is a pro-inflammatory process. So the presence of high CRP or high ESR without symptoms of infection is not indicated for any antibiotic at all.
Okay, next question.
Sorry, Dr. Motaz. Sorry, Dr. Motaz. I mean with these no symptoms that there is no fever, no exit site infection, no pus from from the tunnel, no inflammation around the catheters. Because sometimes we see our doctors in our units who see the catheter with inflammation or maceration around it, and they told the patients that there is no problem. So I mean no evidence of catheter infection with its all types, like exit site infection, tunnel infection, or catheter-related bloodstream infection. If they are all absent, so we should not treat the CRP alone.
Okay, moving to how to reduce the biofilm formation. Is there a way to reduce the biofilm, infected biofilm, as you know?
The biofilm is usually in all catheters. So the best to compete this biofilm is to remove the catheter. So any catheter have the biofilm, but the problem is with the biofilm disruption, I think, which causes bacteremia and septicemia for the patients. So the short answer, I think, is we don't have catheters without biofilm, but we usually fear from the biofilm with infections, with microbes in it, or from the biofilm disruption during the machine. The proper catheter lock with, again, any type of catheter locks will reduce the biofilm. Of course, the toluidine based may be better regarding the biofilm prevention, but I think it is not an evidence-based practice. So I think our guidelines, Kiduki or any other guidelines, does not recommend for sure the toluidine based lock solutions. But I think from our practice, it is better to use toluidine based to decrease the risk for biofilm formation. But again, it is a practice point, not an evidence-based.
Thank you, Dr. Hasan. Dr. Mu'tasim is raising a question about do you have an idea about high sensitive CRP, maybe more appropriate than the usual CRP to determine? But you answered before that it's you're not treating the patients as alike. I think this is a smart answer. Do you?
I think the high sensitivity CRP may raise the probability of infection, but if the patient don't have any signs of infection, we should not treat.
Okay, there is a question about catheter diameter, but it's not a clear question. Another one is the catheter lock with antibiotics, and you said that before that you do not recommend to use it, and the Hazim said that maybe use it. We have a lost access. Thank you, Dr. Hasan, for this elegant lecture. It's a very informative for the younger generations, and thank you for your efforts in the lectures in prevention nephrology chapter. And leave the place to Dr. Yasser Hamid and Dr. Rami.
Thank you, Dr. Mu'taz.
Thank you. Okay, thanks for this meeting. Thanks all for this, and thanks for the questions you have suggested. And I think the answers is more than excellent. And see you next.
في one question from دكتور معتصم في الآخر ال diameter of the catheter.
Regarding the diameter of the catheter, we usually in adults we use 12, 14, or 16 French catheter diameter of the catheter. The proper size of the catheter diameter is usually a 60% of the vein, especially in pediatric population. Why? To minimize the risk of friction between the catheter and the intima of the vein. So when inserting a large catheter in a small vein, the risk of friction will be high and it will end up by recent thrombosis. So I think
the vein diameter
by the ultrasound machine. We usually measure the vein before inserting, especially if it is like external jugular vein. The external jugular, we don't insert the catheter before measuring the vein, and at least it should be at least 6 millimeter in adults to insert a 14 French catheter in it.
Okay. Okay. Thank you, Professor
Thank you.
Mu'taz. I'll close.
Thanks,
you, Yasser.
Hasan. Thanks for all attendees for this meeting, and see you next meetings, inshallah. Thanks, Dr. Yasser. Assalamu alaikum wa rahmatullahi wa barakatuh.
Thank you, Professor Mu'taz, for this very interesting meeting, and thank you, Dr. Hasan, for very, very, very interesting lecture and responding to all questions. And this was really a very interesting meeting, and we have very good attendance in this meeting, and deserves and more. Thank you. See you, inshallah, coming Wednesday, 9 Cairo time, and I hope we have you all in coming session. And تصبحوا على خير والسلام عليكم ورحمة الله وبركاته.
وعليكم السلام ورحمة الله وبركاته. السلام عليكم.